Good afternoon, and thank you, Deborah and Catherine, for two very interesting, albeit fast, presentations. um, One of the things I'm learning as I'm sitting in the room today is that the list of what we don't know is growing significantly longer than the than the list of what we know. There's a message for all of us there, I think. Okay, how does this work? All right, apparently this is the same problem I always have. Maxine, how do I advance? Oh, there, got it, okay. So what do we know from the presentations of this panel and from some of the other presentations earlier today? We know that the level of acuity of hospital-based intrapartum care has increased, partly due to higher rates of induction and cesarean birth. We know that some U.S. perinatal outcomes are worsening and have worsened over the last decade or two. We know that competent and educated nurses improve patient outcomes. It occurred to me to wonder what would happen if all of the obstetrical nurses in the United States were midwives, and what impact that would have on perinatal outcomes. We know that births attended by midwives or occurring outside of the hospital are increasing and have increased. The number is still very small. One of the things that we don't know is what impact access to these services have on that number. You can't have a birth in an out-of-hospital setting or in a birth center if it isn't there. And we know that transitions from one setting to another or from one provider to another are associated with an increased rate of adverse outcomes, and that handoffs require a high level of care and coordination. And this is very much related to good collaborative practices, good collaborative practice. We also know that there is a growing need to expand and to fully utilize the women's health provider workforce, and that is becoming more urgent as we look at the ages of some of the current providers. We have some evidence that collaborative teams of maternity care providers improve outcomes and possibly lower costs as well. And from some of the other panels, we saw some studies addressing that. We also suspect, at least, that current education models for professionals and healthcare providers tend to reinforce barriers to working collaboratively, and that system is also disparate in terms of resources that are devoted to the different providers, the different maternity care providers. As we're trained separately, we develop different views of the world. And building trust requires time, effort, relationships, working together. If your first working together incident is over a difficult case, that's a difficult way to start a collaborative relationship. So what do we need to know? How does nurse staffing affect the quality and safety and cost of hospital-based perinatal care? Deborah said that. Most of the nursing staffing studies were done in non-perinatal settings. So are those patterns the same in perinatal settings? What is the impact of missed nursing care on perinatal outcomes? And particularly, I think of breastfeeding outcomes. All of those times when the perinatal nurses don't have time to do the support and the teaching that we know it has an impact on breastfeeding success and breastfeeding duration. What's the impact, or what will be the impact of technology and electronic health records on workforce training needs and demand? Certainly different training needs, possibly more or fewer providers. I'm not sure that we really know the answer to that question. And what is the impact of patient engagement and shared decision-making models that we're talking about now on workforce training and staffing needs? How can we best include the mother and the childbearing family as an integral part of that perinatal team? And I think that midwives and birth centers have much to contribute to that particular discussion. We need much more data about the process of care. What is it about the various birth settings, the actual care that they provide that's different, and how does that contribute to the outcomes that they accomplish? What are the costs and outcome implications for these new models that Catherine talked about of perinatal teams providing collaborative care? Will it be, how will we train those people? What will the cost be? And along that same line, what provider ratios are optimal for full utilization of the workforce and for high value care? Do we need more doctors? Do we need more midwives? Do we need more doulas? What is that ratio? And I don't think we know very much about that, if anything, at this point. We need to know the answers to those questions. Are we currently utilizing our workforce to the full extent of their education, training, and scope of practice? And Catherine's data seems to indicate that that is not the case. And what are the barriers and incentives to doing that? If we need more or a different variety of workforce, a different kind of workforce, how do we use the ones that we have effectively? And what new team members might be added to this perinatal team besides the mother and childbearing family, which seems sort of self-evident. Who else? What other kinds of providers can help contribute to improve peri outcomes, improve patient satisfaction, doulas, and peer support? There are lots of examples that come to mind when you're asking that question. But those are providers who may require maybe less expensive to train and educate, may require a lower level of education, and may contribute significantly to improved outcomes in ways that we don't really understand very well right now. What are the professional education models that will best prepare perinatal care providers to practice in or to function as part of collaborative teams? And I talked about that briefly. Catherine talked about it. The concept of training providers together, meeting when you're young, and your patterns of communication are not well established yet. What changes are needed in graduate education funding to develop these models? So if we need a different ratio from depending on the level of graduate education funding that's appropriate will be dependent on the optimal level of ratio of providers. They kind of go hand in hand. And what are best practices to develop and maintain competency of these perinatal teams in responding to the need of transfer from one setting to another? What do we know about those handoffs and how they can be done smoothly and seamlessly? And that involves a lot of different things. It involves seamless transfer of electronic health data. And we can do that. We know how to do that, but we're not doing it very well at all, if at all now. What kind of transfers? What are the characteristics of the interaction and of the transfer that makes for the best outcomes? And again, it seems obvious to say, and what kind of communication patterns among the providers? And where does the family come into that communication pattern, and how does that impact their satisfaction with those transitions from one birth setting to another? We need to look at the models that are available to us. What are the best models, both in the United States and outside the United States, that are based on collaborative practice? And how can we replicate them here in the United States or more widely in the United States? What support is needed on a healthcare system level in terms of regulation, in terms of liability reform, in terms of payment reform, in terms of professional education? What kind of support do we need for building those collaborative teams, and what kind of incentives need to be put into place in order to accomplish that? And again, in the last one, just how can we foster this collaboration in general across birth settings, across healthcare providers? And that's it. Thank you.